From healthcare to self-driving cars, from banking to artificial intelligence, whether it's business ethics, corporate strategy, or making productivity savings, academics at Warwick Business School have an eclectic range of research interests. But what impact does that research have in the world beyond the business school precincts? And how is it changing our lives for the better? Well, in this series of Core Insights podcasts, we'll be trying to find out. We'll be bringing together two people who can speak from personal experience about how the theoretical can inform the practical and how academic research can drive real change in the public and private sector. Today, we're looking at healthcare. I'm joined by Dr. Nicola Burgess, Associate Professor at Warwick Business School, and by Professor Andy Hardy, CEO of University Hospitals Coventry and Warwickshire NHS Trust. Now, Nicola, you've been studying the principle of so-called lean management, and Andy, you've been putting it into practice. We'll hear more about that word lean and the quality improvement methods associated with it in a moment. It was pioneered by the Virginia Mason Institute in Seattle, which entered into a partnership of 5 NHS trusts, of which yours, Andy, was one. Well, Warwick Business School has published a report into that collaboration, and Nicola, as the report's author, you're probably the first to be able to tell the world about what's in it. So what did this partnership involve, and has it been a success?
I think the first thing to say actually is that lean actually comes from manufacturing. Over the last 80 years or so, it has become present in many sectors, in virtually every sector around the world, and has been used quite extensively in the last 20 years, I think we can say now, within healthcare and in the UK and around the world. Where Virginia Mason comes in is I think they were probably one of the first healthcare organisations, hospitals, to implement lean right across their organisation. So often what we see in healthcare and in other sectors as well, actually, is that we tend to think of lean as an improvement method, which it is, but then it can sometimes be used in a way that is sort of very tool-based and sort of project-led. And so we see quite a lot of lean implementation, particularly within hospitals, that is isolated within departments. So you get pockets of improvement within organisations. So it's quite rare to implement lean as a methodology or a management system that goes right across an organisation.
Andy, it's very easy, since the technique, if you like, the system was borrowed from automotive engineering and car manufacture, that it's just an alternative to another way of saying cost cutting.
We, in the healthcare setting, as part of the partnership, are very clear that this was the use of lean methodologies, lean tools, but actually, as Nicola's gone to say, that the wider cultural aspects, though, the bringing in of a management system to lead to increased quality. Without a doubt, increased quality often leads to low cost. Getting things right the first time, not having to do things more than once, not having to correct mistakes. But at no point did we see this as being a way to cut costs. We're always obviously cognizant of the costs in healthcare and the limits on expenditure, but this was absolutely not about cutting costs. It was about how do we use these tools? How do we change our cultures to be higher quality?
And in what ways did your ways of working change actually on the ground in the hospital?
They have changed almost immeasurably, and they have touched all different parts of the organisation, from the way we lead that organisation, people in my position, the directors, but right down to you, as you say, the day-to-day workings in every clinical area within this organisation. And one of the best and most simplest examples of that is, I can tell you that in every day within my hospital, on both sites, you have over 90 different areas who will start their day with a huddle around a focus board, looking at what their focuses need to be on that day, what the lessons were from the previous day, whether any mistakes were made the previous day, what can we learn from those mistakes, what goes on. And those And then how do you actually act upon those and what difference you need to make? Then regular use of tools such as what we call PDSA, plan, do, study, act. So you want to make a change, you plan it, you do it, you see if it's worked or not, and then you act on it when you need to change it. Those tools are being used each and every day.
My job with this and how I have been working with Andy and UHCW, as well as other healthcare organisations, has really been to go in and to evaluate the work that they are doing. So rather than me taking an idea to them, it's about, well, let's evaluate the impact of the work that you're doing. Let's understand what works. Let's understand what doesn't. Let's understand how we can improve the efficacy of this improvement method and to keep to assist with the management system and the culture, things like that.
Now, Nicola, you've written about all this and identified routines that foster continuous improvement. One of them, Andy's just mentioned, the huddle, the daily briefing, standing up on the ward, getting an important meeting, but to start the day. But then you came up with one, if you like, initiative that sounds a bit counterintuitive to me. Not a brief huddle, but a monthly 6-hour meeting with CEOs of trusts and senior members of NHS England and senior reps from Virginia Mason Institute. I mean, 6 hours in an airless office, it does sound a bit counterintuitive.
I think it was extraordinary, and I felt very privileged. Every time I attended those meetings, the quality of the dialogue, the honesty, the frankness, the learning that occurred at those meetings was astonishing. And of course, it was bringing together members of NHS England and Improvement, so regulator representatives together with chief execs, holding the chief execs to account, and they held each other to account too. I think there was some, social levers going on of, no one was going to not put themselves forward, and it really kept with the momentum of the change and the transformation that was happening. But the regulator being a critical friend, encouraging them and saying, have you thought about this? But then beyond that, actually, it created a forum of learning, where bringing these organisations together for the whole day, face to face, created new knowledge, and that new knowledge was then being used to shape practice and policy. And so it was really, really important that we did that. It was a significant investment, but I think without it, these things don't work. We do need to invest.
Andy, that kind of approach has been described as relational. What does that mean in the day-to-day running of a hospital?
Okay, well, firstly, just going back to the whole idea of this meeting, as you say, it's a massive time commitment and investment from leaders of hospitals to come together. But actually, it soon became something that we all look forward to doing, and saw it as there was a big return on those investments. Nicola's just mentioned the learning. I have said repeatedly that I never came away from one of those meetings without having learned something that I could bring back to my organisation, to improve my organisation, to improve the way I worked each day. And as you said, we worked as critical friends to each other, challenge each other to how we can move our organisations on. And the relationships became very strong. They were replicated, not just at chief exec level, but across medical directors, across HR directors, and also, very importantly, among what we call our archives and promotion officers. So the people who kind of held and led the process within our organisations, very important part of it. And I don't think that we'd have got as far without the rigour and discipline of having those meetings every month.
I'm sorry to introduce a negative note, but I think it's inescapable. We've been looking at the improvements and the successes of the partnership, but we can't overlook the fact that among those hospitals taking part was the Shrewsbury and Telford Trust, which hit the headlines when a report found severe failings in the maternity department, failings that meant some 200 babies who died, either stillborn or who died shortly after birth, could have lived if maternity care had been better. Now, obviously, it's a personal tragedy for the families, but an organisational failure at the hospital, not either of your responsibilities. But would you agree that this shows that the partnership wasn't without its flaws and that perhaps some systems are resistant to improvement? Nicola?
Yeah, so obviously a really incredibly tragic case at Shrewsbury and Telford hospitals. And I think, as an NHS and in academia, we need to learn from these scandals, and we need to keep learning. I think the NHS has been on a journey for decades now for patient safety. We know a lot of these things. We know the importance of having a receptive culture. People are able to speak out, and with continuous improvement capability. And I think what this example really shows us is again, it's the importance of culture. One of the things that we found in our evaluation was the role that culture plays prior to an intervention. So organisations that had a receptive culture gained the most from an intervention such as lean, a quality improvement method. Whereas I think the message here would be that culture comes first. That having that receptive culture is incredibly important, and I think there's still much more to be done, and we have to keep going with that message.
And Andy, any further thoughts on how it affected the partnership, obviously with Shrewsbury and Telford?
Well, firstly, just reflect what you both said in terms of none of us who heard it through the media or actually read the two reports by Donna Ockenden into the failings of the maternity department at Shrewsbury and Telford could be failed to be moved and shocked with what we read. It was a litany of personal tragedy for lots of people. And that did take part in one of the hospitals associated with this partnership. And it did come as a bit of a blow. But also, picking up Nicola's point there, none of us in any of our hospitals will say that what we're doing is perfect and there isn't mistakes being made all the time. It's how you learn from those mistakes. It's the culture of learning and constant improvement, utilising those tools which are part of this system to then address some of these challenges when they're found. And it's interesting because obviously we were, at the same time this was being investigated at Telford and Shrewsbury, we were hearing for some really good work that was going on there, utilising some of these tools in different parts of the hospital. But what it obviously then showed us is that culture didn't pervade across the organisation. And Nicola mentioned earlier that lean and other tools have been used in different hospitals at different times, but often just used in discrete areas. One of the key learnings from this partnership and this whole movement of the 5 trusts has been that this needs to be seen as a whole organisation piece of work and not in just discrete areas. Because otherwise things can be really good over here and awfully bad over there, like we saw there. So whilst it was a bit of a jolting moment, like it was for the NHS and society as a whole when we heard about what happened, actually it also gives an opportunity to say, what can we do about that? Why has that happened, or how has it happened in an organisation where otherwise good stuff is going on? And as Nicola said, one of the key learnings is that to get all this right about having the right culture in an organisation to land these tools, to land what we're trying to do, and then move forward.
Now, both of you have referred to the word culture. Is part of the problem historically the hierarchical structure in hospitals? One of your colleagues who I spoke to some years ago, Nicola, said he noticed that information, expertise was shared across and down, but never up. So people are working in their silos. They're all working with the same sort of mindset, with the same people in the same, and they don't have exposure to other people doing equally important aspects of the multifarious tasks a hospital needs.
Yeah, I totally agree. So hierarchies and silo working is most certainly a problem, and it does stymie improvement and knowledge mobilisation within organisations. It's a significant problem, but it's not one that we can't overcome. It's something that we can certainly improve. The hierarchy has a place. It is important for many things. I think the point is that lean is what we call socio-technical. So any sort of improvement work that you are doing within an organisation, you can't do it in isolation. You can't improve in isolation. You need to work with others. You need to share that learning. You need to work together to deliver improvement. And that's really important. So where you've got silo working, it's difficult to make that happen.
So does that mean, Andy, you will mix people from different disciplines, different organisations, different departments, and get them to see how the other half works as well?
That's exactly what we do. So when we do pieces of improvement work, we bring people from all different parts of the organisation, we bring new pairs of eyes with them to see what's in front of them. And very importantly, one of the early lessons we learned in this was that we include patients in this improvement work, because they bring with them their pairs of eyes and the experience of what it feels like to go through processes and through systems. So it's bringing all those people together, and it breaks down some of those silos. Well, I will just add to this, in fact, talking about silos, one of the things I've often said is that we work in a national health service where often we miss the N out in terms of people aren't willing to learn from each other from different organisations. And that we've had that classic, oh, it wasn't invented here, or that's not the way we do it here. I think that is really changing in the NHS. I think this is one of the great examples of that. I've already talked about how every time I went to one of our trust guiding board monthly meetings, we talked the 6-hour meetings on the basis, I learned something from colleagues in different trusts. I think on a wider scale, I think one of the silver linings of the COVID pandemic has been we're much more open now as hospitals and as institutes within NHS to learn off each other, to see how we can get ever better. And that helps break down silos between organisations as well as within them.
And how quickly do you see results, Andy? It's all very well to have a blueprint and a template. How long does it take to see actual change?
I think that's a really, really important question. And one I get asked when people are thinking about starting down this path. You shouldn't expect instant results. You can get some very quick results, and certainly by learning off those of us who have already been through the process, made some mistakes, it'll get over quicker. But if you think around, to get the maximum benefit from this, you've got to get culture right and start to see some of the culture changes. That does not happen overnight. Some of the tools you can just pick up and land into an organisation instantly. Those are the idea of, like, I say, for example, keeping things in the right place at the right time so people know where things are. They can make quick fixes, but some of the culture changes you have to accept are going to take a while. And one of the learnings we had very early on from Virginia Mason is we thought it was one of our duties, actually, after a large investment, to share our learnings with the rest of the NHS. But they said, you've got a suite of things you can show that you've made real change to your organisation, because that's the strength of this. It's not about, I've got a quick win in department A or B. It's about how we make a difference to the organisation and the way you run it. And that's the difference between just seeing it in a bunch of tools and a management system.
And Nicola, do you as an academic go in with a timetable? Do this today, do that tomorrow, and we'll see an improvement at the end of the week?
Not at all. No, absolutely not. It simply doesn't work like that. I think right at the beginning, we talked about how lean could be misunderstood as merely a tool or a technique for delivering an improvement to a process. And in that instance, you'll be able to measure improvement, measure change. And that's a very important part of doing improvement, of course. If you don't measure something, how do you know whether you've improved? But then when we talk about organizational change and transformation, the big ticket items, that's what takes the time. And I think there is a danger of becoming too preoccupied on how much money have we saved, how much time have we saved. We're forgetting about lean being a management system, that the importance of culture for patient safety, quality, and lower cost overall. Those are the things that we need to focus on. So I, as an academic who's been looking at lean for a number of years, am quite hesitant about putting too much stress on measuring organizational change, because as Andy said, it will take 15 to 20 years before you can say that you've made a difference to the bottom line.
These things do take time. When we first got into this partnership, we heard from Gary Kaplan, who is the long-standing chief executive of Virginia Mason. At that time, they were 14, 15 years into their sort of lean journey, as he calls it, and said they've still got a lot to learn, like we all have. But one thing he was very clear about is that they made mistakes. They realised there were things they could have done in a different order to make it land in an organisation quicker. One of the great examples of that was they were in years 5, 6, 7 before they really started talking about what we call daily management and standard work. So if you do that earlier in your sort of journey, it makes a big difference. And so we did that. So things can happen quick, but only quickly. It's all relative. It is going to take years to fully change how an organisation works, but you will see some quick wins, and there's some things that just take slower.
Obviously, between the partnership beginning and the report's publication, we've had an unprecedented pandemic in the form of COVID-19. I'm wondering, a question to both of you, how did that change things? And obviously it put the lean machine under pressure. Did it survive? Did it perform well?
We were interested in the same question, Trevor. So during the pandemic, we asked the 5 trusts if we could do some interviews with members of staff in each of the 5 organisations, because we wanted to understand, to what extent the programme, the partnership had shaped the way that they could respond to the pandemic. And we were quite frankly astonished to hear that these techniques, these tools, these principles were used extensively in all 5 organisations, and they really were. And I'll leave it to Andy to provide some examples. But one of the things that really surprised us was actually where an organisation had, let's say, more sceptical clinical professionals who, prior to the pandemic, did not really engage with this lean improvement at all. When the pandemic hit, that burning platform, that shared goal suddenly got them, going out and seeking these methods and seeking individuals who've been trained in lean methodology to help them to redesign their processes and to cope with the pressures of the pandemic.
So one of the things I think we did well at UACW is that through the embedded use of PDSA, that Plan, Do, Study, Act, it meant that we're an organisation who was willing to both learn fast and fail fast. So literally on a daily basis, we were learning new things about the disease. We were learning about how we needed to set our hospital. And we did move a lot of our hospital around, and we would do those in a daily cycle, including chief officers and myself, in making decisions where they were needed. A great example was around very early on in the pandemic, we were learning from partners in other parts of the world, particularly in Italy, about the need for increased oxygen availability for patients, increased number of intensive care beds. And we utilised the tools to see how we could very quickly reassign some of our beds that were sort of normal medical beds into intensive care beds or the like. What that meant was in terms of the oxygen supply for the organisation. And we use those tools to be able to literally come together every day, try something out. Does it work? Yes, let's embed it. If it doesn't, let's try something different. One of the key sayings around this lean methodology and this culture is you're not always searching for the perfect, you're searching for the next best thing. And if you do that quickly and rapidly, you can move on very quickly. And so the tools absolutely came to the fore. And I also echo what Nicola said there, is that even then, some of the skeptics in the organisation saw that this was making a difference and wanted to know more.
Now, you as a manager and you as an academic, Nicola, would always have the principle that the patient comes first. That's the person. It's not a customer. It's someone who has to be treated. But Andy, perhaps this is a bit of a low blow. Am I being naive and deluded to think that hospitals always put the patient first?
No. So you are in some ways. I have stood on many public stages and said, one of the great things about this is it really does truly put the patient first. Whenever you design or redesign a process, you ask yourself, is this best for the patient? Not, is it convenient for the professional? Not, is it just the way we've always done things around here? And actually, many of health services, not just in this country, but across the Western world, are exactly that. They've just been built up around what was convenient for professionals or the way we do things, not always thinking what is best for patients. As I said earlier in conversation, when you try to look through the eyes of a patient, everything you do, what's wasting the eyes of a patient, not wasting times of you as an individual working there, you look at things differently. And that's why bringing patients into the improvement workshops really helps you do that. And it's significantly changed things. Some people outside the health service, they say exactly what you just said. Oh, of course, patients always come first, don't they? Well, I'll argue, no, they haven't. But what I say this does, it really helps you or makes you hold up a mirror against every decision you make, saying, is this putting the patient first?
Now, Nicola, it must be gratifying to hear that your research, all the work done in libraries, in research data and collecting it, poring over papers of an evening in front of the laptop, bears fruit, and that people do see change as a result of what you're proposing.
Yeah, I think my role in evaluating this partnership between the NHS and Virginia Mason has been enormously gratifying. It hasn't been perfect. There are certainly lessons to be learned, and that, you know, the evaluation is the vehicle through which we can learn some of the lessons and improve the way that we do, that we implement improvement across the whole system. But what has been really gratifying, I think, is the way in which leaders in particular have really got behind this. You know, it's not just engagement, it's participation. So it's not just supporting improvement work, it's doing improvement work, it's living and breathing improvement work. And I think we've seen that across all 5 of the hospital trusts, where there has been a significant level of improvement and understanding of what lean really is. I think as an academic, I've always been quite frustrated about misunderstandings of lean, misimplementations, where it's seen as a project or cost saving, as you mentioned earlier. And it's none of those things. These hospitals signed up to transform their systems. They signed up to change culture and to build improvement capability, and they've done that. So yes, it's gratifying.
A question to both of you, and again, it's the reporter in me, perhaps a bit of a low blow, that cynic there, or at least skeptic. I mean, is there any sense, Nicola, that this is a theory of the moment, and in a few years' time, it'll be replaced by another management theory?
I think there's always that danger. And I think that's why, again, the evaluation has been really important. So it's a record of the work done. It's a record of what we've learned. It's a record of what we achieved. And I think certainly within the NHS, perhaps because there's a lot of change and churn, the corporate memory can quite easily be lost. So yes, it's certainly a danger, but I think we are continuing to move forward. And I think having the partnership has been a huge part of it, having the evaluation and being able to share the lessons from the evaluation widely is going to be a really important part of resisting, you know, that kind of danger.
Because I'm sure you've seen them, and the people in the audience that roll their eyes heavenwards and say, I've seen all this before, it's the latest gimmick, it's the latest wheeze. Are you sold on this as the real deal?
I am very confident in saying that if I was to walk out of this organisation tomorrow and come back in 10 years' time, I would still see very clear, visible signs of what we've embedded over the last 7 years as part of this management system.
Well, bringing our conversation to a close now, and perhaps ending where we started, if you had to summarise, Nicola, as an academic, what you bring to the whole picture and what your fellow academics can do in Warwick Business School to help public and private sectors perform better, what's the contribution that you would cite highest?
Okay, so I think being outsiders looking in, but also coming obviously with a wealth of knowledge in terms of the theory behind these initiatives, has allowed us to complement the work, I think. We had what we call a formative role as evaluators. So we regularly shared our findings with the chief execs, with members of NHS England, and got feedback. And so we worked with them. But I think what was really important was we were able to see things that worked or didn't work, and then go away and look at them much more deeper to understand the reasons why. And that really is the whole essence of our evaluation. It's about explaining, not judging. It's not about saying, yes, this worked or no, it didn't. It's about saying, okay, let's unpick this and understand why something worked, or let's understand why something didn't work, and how might we be able to overcome those challenges so that we can further support the implementation.
So, Andy, that was the academic's view on what she did for you. What do you, as the management on the ground, I'm not going to say the real world, hers is as real as anybody's, but how did you benefit in practice?
I think one of the important things it was not just about measuring the improvement itself, because we could, to a certain degree, do that ourselves, but some of the evaluation on how well we were or weren't spreading the learning was really important in organisations, and saying and identifying where different organisations were at different stages in their cultural development and how that makes a difference to how well these tools land. I think that's incredibly important as we look to spread these kind of systems and management systems out across the NHS. And we wouldn't have got to where we've got to at the pace we have without those outside eyes and without that intellectual rigour.
Andy, that's as good a place as any to end our conversation. Andy, thank you for joining us. Nicola Burgess, Andy Hardy, on how academic research can inform improvements in the NHS. I'm Trevor Barnes, and this has been a Core Insights podcast for Warwick Business School.